Yeah, I'm ready. Hi, good evening to all the listeners. It is my pleasant privilege to share this IAE webinar of this month. We have three presentations today. The first one is from Dr. Nitin Berkele. He is so familiar to all of us that I don't need to introduce him to the audience. He was our past president of Indian Academy of Echocardiography, and he is currently working in Jupiter Hospital, Thane. He's a versatile cardiologist, does both echocardiography as well as allied imaging like CMR, cardiac CT, as well as he's involved in interventional procedures. I'm glad to invite Dr. Nitin Berkele to go ahead with this. I think this is third of your series, I think, no, on CT?
Yeah.
Please go ahead, Dr. Nitin.
Thank you, Dr. Shanmugasundaram. I will start. I'll share my screen. Okay. So we have this series of cardiac CT lectures, and we had the part 1 on 2nd July, and then these are the dates. I think those who have not attended the first two lectures, they can very well go onto the IAE YouTube channel and can see the recorded ones. These are academic and non-commercial city lectures, and there are lots of figures, slides, videos, which I have taken from various sources, and those credits are here. And any one of you want to have a deep delving into it can go through these credits. And let me start with the yeah. So now let me start with the presentation. Yeah, 1 minute.
Dear friends, let us discuss the spatial contrast and the temporal resolution on cardiac CT and the volume coverage, the different techniques for that. The definition of a spatial resolution is that it's the ability to distinguish separately two small objects that are very close to each other. While what is contrast resolution? Contrast resolution is the ability of the imaging to discriminate the small difference in the density of a small object from its surrounding. If we compare the CT with the digital X-ray, then interestingly, though the contrast CT has got a very good contrast resolution, that means almost 10 times better than the digital X-ray, the spatial resolution of the chest X-ray, the digital chest X-ray is better than a CT. So your pixel size will be like 0.2 millimeter in a digital X-ray, while it is a 0.6 millimeter on a CT. So the better contrast resolution of CT obviously comes at a higher radiation dose. If we compare all the cardiac imaging modalities for their spatial and contrast and temporal resolution, one can see that the CT has the best spatial resolution. And this spatial resolution is equal in both X, Y, and Z direction. The temporal resolution is very poor in cardiac CT. The temporal resolution is the best with echocardiography, and obviously with cath angiography, which is around 1 to 10 milliseconds. If we look at the fluoroscopic catheter angiography, the spatial resolution is around 0.2 millimeters. So for a CT coronary angiography to match the catheter angiography, you still need a more technological breakthrough. If we look at the contrast resolution, then that is the best in the PET and SPECT. They are very high contrast resolution. However, the spatial resolution is very poor. So coming back to the spatial resolution of the cardiac CT, as we know that the image matrix of a CT is 512 pixels, both in X and Y direction. So your field of vision, the field of vision divided by this 512 pixels will give you the size of your pixel. The so the thing is, if we are looking at the pixel size, which we just discussed as the field of vision divided by the matrix, that is this 512. Once we get the pixel size, which is a two-dimensional structure, if we divide, if the we divide the slice thickness by the pixel size, we get the voxel. So the thing is, the voxel is a three-dimensional structure, both x, y, and z direction, and any X-ray attenuation in that territory is shown as the average attenuation of that voxel on a CT image. So the best way that we can improve spatial resolution is by either reducing the FOV, that is the field of region, or we can increase the matrix size. So the best way to improve the pixel or reduce the pixel size, we try to minimize the field of vision because generally the pixel size will be fixed at around 512. So we can get typically anywhere between 0.3 to 0.8 millimeter of pixel. So most of the CT images or CT coronary angiograms will have their pixel size of around 0.5 to 0.6 millimeter. Now, what is interesting about the CT scan data is that it is an isotropic data. That means you have the resolution of the voxel same in all the direction, whether it is X direction, Y direction, or Z direction. Say 0.5 or 0.6 millimeter in all the three directions. Now, how does that help? So that helps in such a way that whatever plane of image that you want to look at, you have no distortion of the image, and you can do the multiplanar reconstruction without losing onto the spatial resolution. So this is a truly isotropic data set that you get in a CT image. However, the CT contrast resolution, now if, as we discussed in the previous lectures, we know that the range of Hounsfield per units for most of the soft tissue is not that great. It is around whatever 300 to 500. So the thing is the contrast resolution is not superb if we are just looking at the grayscale images. So how do we increase the contrast resolution? Now, the best thing is to administer the iodinated contrast because that creates a very good contrast resolution by changing the Hounsfield units to a great extent. You can decrease the image noise. And how do you do that? You can use the iterative reconstruction, which is a computer algorithm for the CT image generation. You can increase the radiation dose. And also, if you have a little thicker slices, then the noise level goes down. Third is using a dual energy CT, and we will discuss it later. Now, the IV contrast attenuation is optimized by properly timing after giving the IV contrast bolus, because when you have at the peak concentration of the contrast in the field of in the uh, field of interest, you should start scanning. Secondly, we want to have a very high iodine flux at that time, the iodine concentration, and we should have an adequate contrast volume to get a very good contrast opacification. So if we are giving the IV contrast, as you can see that in your field of interest, there will be a gradual rise in the contrast volume and then it will dissipate. So you have an image window, a time window period when you can get the best contrast if you image at that time. The attenuation value of most of the tissue, as you can see here, which is on the y-axis, and on the x-axis is the energy of the X-ray beam. As we can see that as the energy value of the X-ray beam or the kV goes on increasing, obviously the attenuation coefficient is going to go down. However, the relationship is not so log linear for the iodine contrast in the tissue. So you have an earlier the attenuation values reduce, but at range of kVs between say 40 to 60, you suddenly have again increase in the attenuation and then again a dissipation. So one can get a very good iodine contrast related contrast opacification for even lower kV energy values of the X-rays. And this particular KH phenomena of the iodine contrast can be utilized for reducing the radiation dose. Now, there are different ways of reconstructing the image, and one of the way is called as maximum intensity projection or MIP. Now, what does the now how does the computer reconstruct those images? Is that looking at the set of voxels, it identifies the voxels having very high Hounsfield units above a particular threshold, and then joins all those voxels to create a very high a very high attenuation image for those voxels, and that is how it can clearly delineate the vascular space, so artery and its branches, so and so forth. So this is called as the MIP, or the maximum intensity projection. This is very much utilized for the CT coronary angiogram. Now the same one can do it other way around, that is minimal intensity projection, or it is called as MINIP. In this, what the computer algorithm does is that in the set of voxels, it will identify the voxels which have got the low city number or low Hounsfield units below a particular threshold, and then join them together to create image which can delineate, like say, air in the bronchogram or in the trachea and its branches. So this is mini IP. There are different types of display by 3D reformatting, and the most important one for the CT coronary angio is obviously the MIP, that is maximum intensity projection, to see the arteries and the branches. And this you can do by the multiplanar reconstruction and even the curved MPR, so and so forth. Then one can have a volume rendering where you give different colors to the surface of different density objects, and that is very much utilized for the peripheral angiogram and the pelvis and other abdominal structures. And then there is a surface shading which is also possible. So generally the one which is utilized for cardiac CT or in the TAVR protocol will be the MIP, and obviously the volume rendering. Now, how do we improve the temporal resolution? So, what is temporal resolution? Is that you should have as narrow an imaging window, okay, as narrow as possible in the time domain, to so that you can catch the coronary, the snapshot of the coronary without any motion artifact. So you can see the two pictures here with the shutter speed of 1 by 20 and 1 by 25, and you can see that the when the child is caught at a very high shutter speed, you have a motion free and much clear image. Now, this is exactly what you want to do for the coronaries which are constantly moving during the cardiac cycle. As we know that our temporal resolution in the CT scan is limited by the gantry rotation time. Now, as we know that the modern CT scanners have a gantry rotation time of around 300 milliseconds, and we need at least 180-degree rotation, so half of that, like 150 milliseconds. Now, even in the 150 milliseconds, especially at the higher heart rate, we know that we can still get the coronary motion artifacts. Okay, so how do we improve on this temporal resolution? Okay, so there are different ways of doing that. One is called as multi-sector reconstruction, and the second is that you use two X-ray tubes. Okay, and let us see how it is done. So as we know that when we are using a single sector reconstruction, the our temporal resolution would be limited by the half the gantry rotation time. Okay, and this is our imaging window time, imaging time window during which we are going to catch the coronaries. Now, suppose if you want to, if you do in such a way that you acquire a sliver of this pie in different or the subsequent cardiac cycles. Like suppose here this 180 degrees, 60-degree data you acquire in one cardiac cycle at that particular phase. And similarly, at the same phase in the next cardiac cycle, you acquire the next 60 degrees and then acquire the next 60 degrees. Then theoretically, you are improving on the temporal resolution by reducing the time of scanning to almost one third. So this is called as multi-sector reconstruction. So obviously in this, you will have you will need multiple cardiac cycles, which with a very, very stable rhythm, because you have to catch the phase exactly at that moment. And theoretically, it looks very attractive. However, theoretically, though it looks attractive, you should have a really, really stable RR interval because you have to catch that exact phase. So as you can see in this picture, you have acquired this 38 millisecond in this cardiac cycle, next 38 millisecond in this cardiac cycle, and next 38 milliseconds in this cardiac cycle. So you have almost improved your temporal resolution 3 times. Okay. So for the simple reason that suppose if it was 150 milliseconds for 180 degrees rotation, then you can acquire 50 millisecond temporal resolution by multi-sector reconstruction. However, there is a very complex relationship between the gantry rotation and the heart rate. So it is not really possible for all the heart rates. Okay, so what happens is that the not only the multi-sector reconstruction requires a very steady heart rate, but it also so it is only possible for specific heart rates because of this complex relationship between the heart rate, the gantry rotation time, the pitch that you are using for the helical scan. So most of the vendors will have their fixed formula for that particular heart rate, and they will not allow you to override that. So either you can have one, like for a G machine, you can have 1, 2, or 4 sectors. For Philips machine, up to 5. Siemens, one tube can have 1 or 2 sectors, so and so forth. So remember that this will be feasible only in certain patients and not in all the patients. So was one way of improving the temporal resolution by reducing the time window for catching the coronaries exactly at the same phase. The next way is to use two tubes or the Siemens dual source scanner. So here what do you have? Here you have one tube and the opposite side you have the detector array, and then you have a second tube and the second set of arrays. Both are at 90 degrees to each other. So what happens is that when you when the gantry rotates, each X-ray tube has to scan just 1/4 of the perimeter, so that at the near simultaneously both the tubes together can actually acquire data through the 180 degrees arc. That is what we need to generate one sector of your image. So interestingly, now your temporal resolution suddenly doubles, or your the imaging time window period can get halved, or it is just 1/4 of the gantry rotation. So if your gantry rotation time is say 160 millis, if your gantry rotation time is say 300 milliseconds for the entire 360 degrees, then 300 divided by 4, so that will be somewhere around 75 milliseconds. You can improve the temporal resolution, and more importantly that you are acquiring that particular phase simultaneously, because each of this tube is acquiring data from the 1/4 of its rotation. This particular thing of having two tubes together in the Siemens dual source can improve your temporal resolutions by a factor of 4. That means almost just 1/4 gantry rotation time. The this per- so the, so that is how, as you can see, that when you have got only one X-ray tube, you suppose this is your imaging time window, you have almost halved it by using a dual source CT. So if we summarize the different ways of improving temporal resolution, as we can see here that or if we look at the different ways of scanning for CT coronary angiograms, as we can in this particular thing, you can look at that this is the retrospective ECG gated helical scan mode with current modulation. That means you are just increasing the X-ray beam strength only in the late phase of diastole, and then along with your imaging window period, you are also having a time on either side, which is called as padding. And this is obviously the helical scan, which has got much higher radiation. And one can utilize it even with a little bit of irregularity of the heart rate, because you can catch a good phase in each RR interval. Then we have obviously the step and shoot, or the axial sequential scanning, where we have got this where you activate the X-rays exactly at a particular phase, that is 70% of RR interval. And once you have taken one volume data set, you move the table and take the second volume data set, move the table, take the third volume data set. And then you have uh, a prospective ECG triggered high pitch helical or volume scan. And I think we'll discuss that in detail. So the temporal resolution depends upon the gantry rotation time. It does not depend upon what protocol you use. So remember, the limitation of your temporal resolution is only the gantry rotation and not the type of scanning you are using, whether it is prospective, retrospective, whichever way you are doing.
Okay. Okay. So that was that was related to the temporal and the spatial resolution on a CT scan, and you can see that it's quite a complex technology, and it is continuously evolving. And with the photon counting CTs. Now the CT coronary angio resolution is now almost rivaling the cath angio because it has come down to almost 0.2 millimeters. So I think future probably the future is for the photon counting CT. Currently they are quite expensive, but I think as the time goes, they will become more ubiquitous. Thank you.
Thank you, Dr. Natin. I think, like I would say, physics made simple. Um, certain terminologies which I was not able to understand when I was reading books. I think you made it so clear, and it looked very easy now. I have few clarifications to be made with you. You mentioned slice thickness has to be more to have a better resolution. Is it right? I was under the impression that slice thickness should be less to have a better resolution.
No. The thing is, the
Yes.
noise level is reduced when the slices are thick because
Yes.
you get a composite signal. But as you have as the slice thickness is less, obviously you will have the best resolution. So you want the smallest voxel as much as possible. But
Right.
if you go for a smallest voxel, the noise level also goes on increasing. So there is always a trade-off.
Okay. And can you just, tell us a little more detail about prospective and retrospective ECG gating?
Yeah, actually that we had covered in the last lecture.
All right, then, we'll leave it
Yeah,
for the
because
last.
it would be there on the YouTube channel.
Okay.
We have covered that prospective and retrospective
Yeah.
instigating. Yeah.
Are there any, suggestions or contributions from other faculty members? Thank you, Dr. Nitin.
Thank
And
you.
then it will move on to the second presentation, that comes from my friend, Dr. Veeramani, who is now holding an administrative post in Government Medical College in Dinnikal, close to Madurai. He was heading the department of Madurai Medical College for a considerable amount of time. And during his period, the fellowship training program, as well as the interventional cardiology program, reached greater heights. Credit goes to Dr. Amudan, who guided him so well. And he had been an executive member of IAE, and he has a lot of interest in performing echoes both in the institution as well as in public charity programs as well. He participates very regularly. He's honorary secretary for Madurai Cardiology Society. He had been honorary secretary of Indian Medical Association in Dindigul, and he is a member of High Power Committee of Tamil Nadu Government Management Program. Currently, he is also a Senate member of Tamil Nadu Dr. MGR Medical University. And he had contributed, chapters to IAE textbook as well as textbook of 3D echo edited by Dr. Amudan. So he has a combination of administrative interest as well as academic interest. Over to you, Dr. Veeramani. You can present your case on RV cardiomyopathy now. You are muted.
Good evening, sir. It's a great opportunity given by the IAE Delhi, sir, and I am going to discuss about the how to diagnose the arrhythmogenic RV cardiomyopathy. Sir, is it audible, sir?
audible.
But you are
little
not
bit of-
very well audible.
Little bit echoing is there. Your voice is not
Yeah.
so clear.
Okay.
If you probably come closer to the system, probably it will help.
Yeah. So, multi-parametric approach in diagnosis of arrhythmogenic cardiometry is a topic, sir. And it's a rare type of inherited progressive cardiomyopathy. If the cardiac muscle tissue dies and is replaced with the scar tissue, and because of the replacement with the scar tissue, the cardiac conduction disruption can happen, which will result in arrhythmias. The life-threatening arrhythmias is very much common with the arrhythmogenic cardiomyopathy. It usually affects the young adults and can cause sudden cardiac death also. And what is the pathogenesis of ARVD? The mutation of a desmosomal genes, that is a desmoplakin, plakoglobin, placoglain, and facopilin, and the non-desmosomal genes like desmin intermediate filaments, where the mutation causes the defect in the linking site and interrupt the contiguous chain of adherence, which results in excessive stress, and the stress causes the cell isolation, that is apoptosis can happen, progressive loss of myocardium, and fibrofatty replacement in the place of myocardium is happening in the ARVD. And what is the pathology and histopathology? The progressive myocardial cell death by apoptosis occurs in between the epicardium and endocardium. There is a midneural and the external layer of RV myocardium. Where it starts from the epicardium and proceeds toward the subendocardium. There is sparing of the subendocardial layer can happen, and the IVS, tubercle and papillary muscles are spared. And why right ventricle is affected by means of ARVD? That is genetically determined abnormal development of right ventricle due to the mutation of DHAN transcription gene concerned with the right ventricle development. Where this happens? The dysplasia commonly involves the triangle of dysplasia that is formed by anterior infundibulum, apex of the right ventricle, and inferior surface of the right ventricle. And associated with it, hypertrophy of tubercle, papillary muscle can also occur. Here is the triangle of dysplasia. The inferior diaphragmatic aspect of the right ventricle and anterior infundibulum, the right ventricular apex. This area is very much commonly affected by the ARVD. And here comes the microscopic picture in which in between muscles there is scar tissue and fibrofatty infiltrations are there. And what is the epidemiology? Regarding the ARVD, it's first identified in 1977, and the incidence is 1 to 6 per 10,000 in general population. And the Mediterranean South US, it can happen, it goes up to 17 to 40 per 10,000. In Italy, it's usually called the Venetian disease, the Venetian, the Greek, Italy, it goes up to 44 per 10,000. The male preponderance is very much common because of the increased exercise by means of the male, and the phenotypic inheritance significance, the male is commonly affected, and 3 to 4% of sudden death in sports in less than 35 years happen with the ARVD, and 5% of sudden death in less than 65 years of age. What is the triad of clinical features in case of ARVD? Palmoplantar hyperkeratosis, woolly hair since dense, rough, bristly, steel wire-like hair, and the palmoplantar keratosis starts when uses the hands and feet. When the patient uses the hands and feet between the age of 6 months to 1 year, it's it is getting started. And the ECG, what it shows, 90% of patients, arrhythmia in adolescence can happen, and they are also in early adult life. CCF in 25% of patients, and the annual total mortality is 3%, sudden death is 2.3%. This is the very clinical feature. The woolly hair happens, and then palmoplantar keratosis, and the microscopic picture of the fibrofatty replacement. And that is an important point in the ECG, that is epsilon wave. Epsilon wave, that is the epsilon wave, and there is a BP, where ventricular tachycardia was LVB morphology, and it's most likely the RVOT BP. And here comes the epsilon wave. We can clearly see immediately after the S wave, there is a terminal notch is present in the QRS complex. It is due to only the slowed intraventricular conduction. It shows the slowed intraventricular conduction that will lead on to aberrancy. And ARVD, the disease includes the spectrum of abnormalities from very minimal change to extensive involvement of much of the RV. Sensitivity and specificity of echocardiography for the diagnosis depends on the extent of abnormalities and the specific phenotype. MRI has largely replaced nowadays in the echo for characterizing the abnormal tissues within the RV. The abnormal tissue characterization is very much easily possible in the MRI. What is the use of signal average ECG? Nowadays we are going through echo and PET CT scan as well as the MRI for diagnosis. Previously, the signal average ECG was very much useful. The 25 Hz high pass filter in special attention to Z lead will expose the epsilon wave and to demonstrate the late potential and arrhythmogenic potentials. These ECG changes are due to the parietal block, that is an intraventricular myocardial defect, not due to the septal block, that is a specialized conduction system block. So it's an intraventricular myocardial defect that happens in the ARVD. What are the features of echocardiography? The RV myocardium exhibits a hyperechogenic appearance, reflecting the presence of the fat and scar tissues within the RV free wall, especially in the triangle of dysplasia. And the dilated RV and RVOT is happening. Focal RV, regional wall motion abnormality can happen, and the localized aneurysms of the RV free wall. That is seen in this picture. The RVOT is dilated, RVOT is dilated in the Flax view. As in the short axis view is also demonstrated. The RVOT, the size is 32 millimeter, and the epical aneurysm is very much demonstrated, and the excessive trabeculations in the RV, especially in the RV apex, and the hyper-reflective moderator band. These are all the very few features of ARVD by means of echo. And what are the major criteria to diagnose? There are major criteria and minor criteria by means of which we can diagnose the definitive diagnosis, as a borderline diagnosis, as a probable diagnosis. By means of if it is a definitive diagnosis, there is two major criteria, and one major criteria and two minor criteria, four minor criteria. We can definite diagnosis. In the case of probable diagnosis, we have to get for one major criteria, one minor criteria, three minor criteria. Likewise, the possible is three minor criteria. They are allowed to diagnose. What are all the criteria we have to know? So that is the Plaques RVOT. In Plaques view, the RVOT size is, if it is more than 32 millimeters, and the parasol short axis view, the RVOT is more than 36 millimeters, and the right ventricular fractional area change, that is less than 33%. These are all the major criteria above to the intestinal volume in body surface area is more than 110 ml in the case of 110 ml per square meter in the case of male, and 100 ml per square meter in the case of female, and the RV ejection fraction is less than 40%. These are all the major criteria. And the minor criteria, the Plaques in view, the RVOT size is more than 29 millimeter and is less than 32 millimeter. Likewise, the parasol short axis view, the RVOT size is more than 32 millimeter to less than 36 millimeter. RV fractional area changes more than 33 but less than 40. This comes the minor criteria. Go to the MRI. What are all the things we have to see? We can see in the MRI that it's a non-invasive investigation. Ability to characterize the tissue is possible. Differentiate, that is the tissue characterization. The differentiate fat from the muscle can happen. But what are all the limitations of MRI? RV free wall thickness is 4 to 5 millimeter. Motion of sufficient quality, the spectral resolution to qualify the RV wall thickness. Normal epicardial, pericardial fat, difficulty in identification.
Dr. Viramani, we can hear you.
Dr. Viramani? I think probably it's lost now.
His sound is not there.
I think he got disconnected, I think so.
So we can go to the next speaker then or somebody or Nitin can give his views on this subject and then or you can give your views and then we proceed to the next topic or क्या?
The morphological
He's back,
analysis.
sir.
Sir?
Wait a minute, please complete your presentation.
Yeah, okay.
And in between, you were disconnected. Yeah.
Sir?
Your
Please go
voice
ahead.
is not very clear throughout the presentation.
Sir, it's audible?
Audible, but not very clear, Veeramani. Anyway, go ahead with the presentation. I think you are.
Try to finish as early as possible, huh?
Yes, sir. My case is that here are the various pictures of RVOT dilatation and all that in the MRI.
Presentation.
The angiogram is the gold standard for ARVD.
Can you please share your presentation again, please?
Veeramani, share your presentation.
Okay, okay. The case detail here, 55 years old male with recurrent episodes of VT and inverted with cardiovascular and ECG sinus rhythm and RBP epsilon waves present, echo features are. In flax view, the RVOT is dilated.
So your presentation is not there. So just click onto the share button, the green button, and reshare your slides, please.
Then come to your summary slide.
Yep. Now we can see your slides, please. You can
Okay,
show
okay.
your case. Yeah.
Okay.
Go to
You
the.
can come on, you can enlarge it, yeah.
Yeah. It's a parasol long axis view is the usually the LA and aorta is equal, more or less equal to the RVOT, but here it is the RVOT is RVOT outflow RVOT is directed. Similarly, in parasol short axis view also its RVOT is very much dilated. We have demonstrated. And in the cartilage muscle level, it's also RVOT is dilated. Here the apical aneurysm is there, and RV is very much dilated.
As you are not very well audible also, so can we come to your summary slide? Because we can't hear you well.
What, sir?
We can't hear you well clearly, so why not come to the summary slide? Because we can't hear you.
Here the TAPSE is less than 1 centimeter, and then the fractional area change is 24.2 m only. It's 24.2. And the echo findings here the dilated RV and RVOT, prominent repercussions noted in the RV, moderate RV systolic dysfunction, and the RV function is the RV fractional area change is 24.2. If usually it's more than 35, it has to be. TAPSE is 6 millimeter only. If it usually it's more than 18 millimeter. So the RV and RVOT dimensions, the proximal RVOT is 34 millimeter, distal RVOT is 37 millimeter. RV measurement in the inflow view is 58 millimeter. Basal level RV is 47 millimeter, and mid level 43 millimeter. RV length in apical A4CBU is 78 millimeter, and the RV free wall thickness is 4 millimeter. Adequate LV systolic function is demonstrated. So what is the final result? The diagnosis case of arrhythmogenic RV dysplasia and had recurrent VT, it was cardiovascular. RV dilatation and hyperechogenic appearance, reflecting the presence of the scar tissue and reduced the RV function. The single chamber automatic implantable cardiovascular defibrillator implantation done, and echocardiography is useful to diagnose the ARVD, cost effective when compared to the other investigations in the form of PET scan and myocardial biopsy, and it is easily available. So echo is preferable for the diagnosis, and we have to confirm with the MRI for the diagnosis and the management. And the prognosis also, echocardiography is very much useful in getting the improvement with the RV function. Thank you for the patient.
Thank you, Dr. Vinamani. I'm sure you would have done cardiac MRI for this patient.
Yes, sir. Cardiac MRI.
Just tell the findings.
Cardiac MRI, in cardiac MRI, the RVOT and the apical aneurysm has demonstrated, sir. But
Okay.
here, because of the echo, we have only shown the echo, that we didn't show
Right.
the MRI.
Okay, thank you, Dr.
Sure.
Vinamani. Sir, do you have any
I think
suggestions?
let us come to the next speaker. I don't know what is the time.
Right.
Yeah.
Yeah, I think Dr. Monish is there.
Yeah.
Waiting.
You can
I'm
give a
happy-
brief introduction, huh? Just a brief.
I'm happy to introduce Dr. Monish Tomar. She's a pediatric cardiologist with rich experience in pediatric imaging, starting from fetus to adolescents. She's a pediatric cardiologist at LLRM Medical College and Newtema Hospital, Mirror. She's a visiting pediatric cardiologist for AIMS Rishikesh, and she's a great academician, and she's a regular participant of IAE meetings, very active IAE member. I'm happy to introduce Dr. Manish to the audience. Dr. Manish, please. You are muted, Dr. Manish. Yeah.
So, very good evening, and thank you, sir, for kind words, and thank you, Parashar, sir, for giving that interesting topic again to me. Little bit modification with that. So it is basically Doppler interrogation of aorta, of descending thoracic aorta. How can it help us to reach the clinical important underlying issues? So starting with the case of a 6-year-old male child presented to us with the history of 1 week only, fever, tachypnea, respiratory distress. He was a sick child presented to the emergency. On examination, there was cardiomegaly, liver was enlarged, pulses were feeble, and he was in a sick state. X-ray, there was cardiomegaly with pulmonary venous hypertension, and ECG, sinus tachycardia. And this was the echocardiography, severe left ventricular dysfunction. There was MR, there was TR, there was some AR. So a little bit of everything was there. Structurally, heart was fine. There was no coronary issue, no arch anomaly. So practically severe acute onset ventricular dysfunction with the possibility of the myocarditis. And this was a short axis view. You can see how bad the heart is, globular hypokinesia. And on M mode, also, ejection fraction was hardly 20-25%. And this was the descending arch view. We always obviously have to profile your arch of aorta to rule out coarctation of aorta, to look at the flow pattern through the aorta. So you can see there is significant diastolic flow reversal, and that is being shown on the M mode color Doppler of the descending thoracic aorta. So there was systole, and then the diastole up to more than mid diastole, there is diastolic flow reversal. And this is the pulse wave Doppler across the aorta. So there are many findings in this single image. So if you look at the pattern, the waveforms are the velocity of the pulse is varying with the respiration. So there is a sort of marker of the pulsus paradoxus here. Before that, there is diastolic flow reversal. And if you look at the ratio of the antegrade flow plus retrograde flow, it is 12.2/5, almost 50% of the diastolic flow reversal, which is very significant. In aortic regurgitation, to quantify it moderate to severe, it is more than 27% is correlated with that. So it is that significant flow reversal here. So pulsus paradoxus. And the third important interesting finding is the bifid, or the peak of the aortic flow. So there was S1 and S2 velocities are seen in the one phase of the cardiac cycle. So these are the three important findings we can just find from the pulse Doppler across the descending thoracic aorta. And this is abdominal aorta. Again, same thing. There is diastolic flow reversal in the abdominal aorta. So what is just few words about the biphasic Doppler pattern of the descending aorta? It is being reported. The study was done for the adult patient more than 65 years of age with severe aortic stenosis, and they showed this particular pattern. And the explanation for that they gave is in the disease stage, ability, resistance, systemic vascular resistance, ejection, everything is getting disproportionate, leading to this particular pattern. In our patient, there was no aortic stenosis, but because of very low cardiac output, there is high systemic vascular resistance, leading to this interesting phenomena in our patient also. The investigations showed very high NT-proBNP. He was stabilized by the cardiac medication, IVIG given with the Lasix cover because with the possibility of the myocarditis. And this is the echo just after 48 hours of the admission. NT-proBNP has come down significantly from 25,000 to 11,000. And this is the flow reversal again. So if you look at these numbers here, the ratio of the antegrade flow and the reverse flow is 22 by means almost 25% only. That was 50%. So the stabilization which is being showed by the NT-proBNP clinically and on Doppler also, you can just very well comfortably convey that the child is getting better hemodynamically. Though EF is still bad, but hemodynamically with the NT-proBNP and the clinical condition of the patient. So coming to the normal Doppler pattern of the aorta, you have an antegrade systolic forward flow with the brisk episode with the LV contraction, velocity from 80 to 100 from pediatric to adult, and it is followed by a brief low velocity wave of the retrograde flow, which is a reflection of the distal peripheral circulation. So this is the normal flow pattern which we see in all patient or all healthy adults with the normal flow pattern. Blood flow in this descending aorta. So multiple factors are playing here. It is ejection force, it is the pliability of the aorta, and it is a compliance. So everything is playing a role. When anything is getting disturbed, you will get the abnormal flow pattern across the descending thoracic aorta. So abnormality could be systolic. You may have low systolic velocity because of low cardiac output. You have high velocity because of increased cardiac output like anemia or tachycardia. You have systolic biphasic pattern, which we have just discussed, pulsus paradoxus, all the pulsus alternans, which I will show you. Or you may have continuous flow. So from systole, then continuous, which is significant aortic artery obstruction, coarctation of aorta, which all know, nothing new about that. And the diastolic flow reversal. For the diastolic flow reversal, you have structural issues, you have hemodynamic issues. A lot of things are there leading to the diastolic flow reversal in the aorta. So this is typical pattern of coarctation of aorta. And here, interesting pattern in an 8-year-old child, again with heart failure, severe left ventricular dysfunction, there is mitral regurgitation, and this was so severe systemic arterial hypertension leading to compromise hypertensive cardiac failure. And this is the Doppler pattern. This is again very interesting by the just putting a Doppler. This is across the abdominal aorta. You see the strong and the weak pulse, which is a feature of the pulsus alternans. Whenever cardiac output is very low, it can be left-sided, right-sided, or bilateral, depending on the which ventricle is getting compromised. So just putting that Doppler across the aorta or the pulmonary artery, you get this beautiful pattern. And obviously, presence of all these things says that patient or the child is hemodynamically very sick. Now coming to diastolic flow reversal in aorta, this is PD and aortic regurgitation directly come to our mind when we think about, but there are a lot of things are there. So this is just a patent ductus arteriosus, and there is diastolic flow reversal in the aorta, and it is up to level of the PDA. Now during the diastole, if you look from the ascending aorta and from descending aorta, both flow in the diastole continue into the low resistance circulation, which is the pulmonary circulation. So this is the M mode across that diastolic, across the descending aorta, colored M mode. The patient underwent device closure and doing fine. Severe aortic regurgitation, the flow pattern, if you look, compare with the previous one, here it is into the ascending aorta. So whole of the color Doppler M mode will show a red flow pattern in comparison to the PDA, where upper one was a blue and the lower one was, and both are going into the low vascular resistant aortic circulation. If it is not PDA-AR, you have to find other causes of the structural causes especially, and this is a large aortopulmonary window presenting with cardiac failure in early infancy, and you have to go for surgery. There's nothing like waiting for in these patients. There's nothing like spontaneous closure. Usually AP window is very large than when they present in infancy, and you have to go for the early surgery. Other thing is the ascending branch pulmonary artery from ascending aorta. It can be left, it can be right, but usually more commonly it is right. Again, the answer is surgery, nothing like waiting. You have to intervene them early at the time of diagnosis. So by second, third month of life, they present and they have to go for the surgery. Truncus arteriosus, we all know, again present with the cardiac failure with diastolic flow reversal because the circulation is going into the pulmonary artery with the fall in the pulmonary vascular resistance, and they again need to intervene within the 3 months of age. Coronary AV fistula, and again a runoff lesion, stealing the blood from the systemic circulation, from coronary circulation, and if it is large, will lead to the significant diastolic flow reversal in the aorta. A rare type of aortic regurgitation is the LV to aorta tunnel. So here the regurgitation is not through the aortic valve, it is through a tunnel just close to the aortic valve, and that is coming from the aorta to us left ventricle. Again, it is a runoff lesion, will lead to the diastolic flow reversal in the aorta, and again this is a surgical entity to intervene. Rupture sinus of valsalva with or without aortic regurgitation will lead to flow reversal in aorta. So this is another very important cause leading to flow reversal in the descending thoracic aorta. Need to be fixed by either device or surgery. Most of the cases are for the surgery, but in very selective cases, now significantly it is being done by the device closer also. VSD. VSD is a very commonest congenital acyanotic heart defect, but clinically the VSD is getting restricted. Clinically, child is getting better, and because of restriction, because of aortic valve prolapse, ultimately they will develop aortic regurgitation. Slowly, if we miss that finding on echocardiography, then the child present later with the significant aortic regurgitation, and obviously this should not happen. Significant AR in any patient with the VSD means we have missed a lot of time these patients, and now he's coming further with cardiac failure requiring aortic valve surgery, which is a lifelong disease adding to the simple ventricular septal defects. Flow reversal, when you don't find intracardiac lesion, then you have to look for the hemodynamic issues or the extracardiac issues like vein of Galen malformation. So when you put your probe over the aorta, there is flow reversal. Intracardiac, there is nothing to explain that. You have to put your probe over the cranium of the baby. These are basically newborn infants presenting with cardiac failure, and this entity need to be dealt by the neurointerventionist, and we have to involve them to close these things by the coil closure of vein of Galen malformation. BT shunt, acquired issue in patients with the congenital cardiac defect, cyanotic heart defect, decreased pulmonary blood flow to buy some time, you have BT shunt or large collaterals, they also lead to the aortic runoff. A rare entity is the subclavian artery to SVC fistula. I don't have echo of this patient, but we did device closure. This was again a 3-4 month old baby presented with cardiac failure with features of the SVC syndrome. His head was too big, and the fistula was from the subclavian artery to the SVC. We did device closure of that, and in this situation, the SVC was also obstructed. So we did a stenting of the SVC area. So these are the things outside the heart. We have to look everything. There is flow reversal. It is something very significant. Whether hemodynamically or the structural, we have to look at all the parts. So PDA, AP window, PA from a long list of the lesions are there, to structural lesions to lead to the diastolic flow reversal. A list is there of the hemodynamic lesion. From the adult point of view, it is the systemic arterial hypertension. The studies have shown systemic arterial hypertension, when there is associated diastolic flow reversal, the chances of CV are higher. So we have to be careful because of the embolization of atherosclerotic plaque going through the carotids. So this is the association is significant noted in that study, and obviously if we are seeing that, we should put a note on that, and we need to have more watch for these patients. Low cardiac output, as I discussed with the dilated cardiomyopathy, Kawasaki disease, MISC, obstructed, when it is right side dependent circulation or left with very low cardiac. Effectively, it is a low cardiac output will lead to a rise in the systemic vascular resistance and leading to flow reversal into the aorta, which is a poor prognostic factor, even if associated with the isolated TAPV. So we have to be very careful, and we have to note it, and we have to put a point to the surgeon also that this is particular entity situation is there. So we need to be extra cautious in the post-op management. High cardiac output stays, anemia, thiamine deficiency, hyperthyroidism, liver cirrhosis, and obesity. All these things are associated with the flow reversal. All these things says that the lesion, the issue is significant and have to act actively in these patients. This is echo of a child with TAPVC. Look how bad the heart is. LV is hardly there. It is just compressed by the right ventricle. There's significant TR, severe pulmonary arterial hypertension, and severe pH is there. Diastolic flow reversal is there again because of the low cardiac output and the high systemic vascular resistance. The studies have shown that presence of diastolic flow reversal due to low cardiac output carries a very high mortality in patients with the TAPVC, and these are basically obstructed TAPVC. Sick newborn babies are there. Means you need to be ready for the ECMO and all these things in patients. From diastole, the systolic flow reversal in aorta in transverse arch is basically when the PA pressure are suprasystemic, like hypoplastic left heart syndrome. So here the whole of the circulation is dependent on the PDA. So PDA is feeding the aorta, PDA is feeding the cerebral artery, and PDA is feeding the descending aorta. So in systole, you will find flow in both circulation. So this is sad disease with a poor prognosis, but these are just interesting Doppler findings in these patients also. So thoracic aorta Doppler should be taken in all patients while doing echo. We should know whether it is pediatric or adult. This is a very simple, just few seconds you take. You can't miss the aorta. You should put a Doppler there, pulse wave Doppler. If you are thinking if it is like it's flow reversal is there, better to take M mode, because that will tell you in time the duration of an. If you take VTI, that will tell you the significance of the flow reversal in aorta. Congenitally, structural wise, we have a lot of list leading to flow reversal, and structural causes are always significant. There's nothing like wait and watch. You just do initial medical stabilization and go for the surgical correction. Hemodynamic factors, if these are there, the means patient is sick, you need better ICU support, inotropes, whatever support depending on the clinical condition of the patient. These are the sick patients, so obviously your morbidity and mortality may be going too high. You have to be very vigilant when you find a diastolic flow reversal in aorta. So a simple pulse wave Doppler across the descending thoracic aorta will tell you a lot of things, and I feel it should be looked in all patients, for whatever the indication of the echocardiography. Thank you.
Thank you, Dr. Manish. I think you had given an exhaustive, list of illnesses where the aortic Doppler interrogation would be of, benefit. This is one of the neglected areas in adult echocardiography. I would insist that, suprasternal viewing, Doppler interrogation, not only the arch, as well the thoracic aorta, abdominal aorta, should be routinely done in people, particularly those young hypertensives. We should do this. It's quite a good presentation. When the situations like aortic runoff situations is one, okay, and you have enumerated, the high flow situations like anemia, very, very high cardiac output situations. Does the reversal extend up to the end of the diastole, or it goes up to only mid diastole?
Yeah, in this situation, when it is obesity, anemia, so it is mid or early. When it is beyond that, then it is usually associated other significantly. Like for AR, they give the particular number. If it is more than 20, like VTI of the integrate and retrograde flow, the ratio, if it is more than 27%, it is, even if you are under, like per operatively, there was sort of, you are underestimating aortic regurgitation jet. So better to take this also to add that we are not underestimating the lesion.
Okay, thank you.
There's one question in chat box, sir.
Okay.
This is how to manage large PDA in Eisenmenger syndrome. For Munesh only.
Eisenmenger syndrome, whether it is the lesion has to be large, whether it is VSD or PDA, means no closure of that lesion. So we are not going to close that. It is only medical management. And medical management, now we have the pulmonary vasodilator, a good list we have. So good hydration, Usually, because they are polycythemic, we need iron supplementation in all these patients. We need to avoid exertional, like going to high altitude, this type of activity. Pulmonary vasodilator should be used. Good hydration maintenance is there. They are high risk for the bacterial endocarditis. So we give that instruction very carefully. So these are the very basic thing we need to tell the family. Then finally, it is the transplant. So if surgery wise you ask, it is the transplant, lung transplant, because it is PDA, you can manage with lung transplant only. When it is complex congenital heart defect, you go for the heart and lung transplant, and they have a different outcome for depending of even in simple VSD, whether it is you are doing lung or the heart and lung transplant, outcome is better when you do both. So that is a surgical point of view, but lesion not to be closed. That is very important. And when there is isolated primary pulmonary arterial hypertension, now we create a port shunt. That is you put a stent across, or you do perforation and put a stent there to create a PDA. So PDA is life-saving here. You have to continue with that.
So no more questions from the audience. Yeah.
Dr. Simi, I think you can, thank the speakers and wind up the session. Thank you.
Thank you, all the speakers. You've all done a wonderful job. See you till next month. Yeah. Bye-bye.
Thank you very much.
You
Good
can all-
night, everyone.
Thank you. Good night.
Thank you. Good night. Bye-bye.
Bye.